Some things are all around us and we don't even know it. Air, unless it moves. Pain, unless it's ours. Mental health challenges, unless we're attuned. Be one who knows about mental health disorders, destigmatizes them, makes and is the difference.
Addiction. It's still a word filled with stigma and misunderstanding. Inaccurate portrayals in movies have blinded our eyes to see that an addiction can happen in anyone's life. Overwhelming stress, unresolved trauma, including childhood trauma, and many other factors can lead us to practice behaviors or consume harmful substances to temporarily numb our pain. But there is hope for a lasting freedom. Adventist Recovery Ministries can help you find the path to life. Join a journey group to experience a Christ-centered 12-step program. Be trained as a facilitator to host a group in your church or community. You can also be trained as a sponsor or equip your church to be a trauma resource center. You can be someone's hope for freedom.
Life is challenging. Figuring out who you are, what you want, and how to get there, there's no instruction manual. Questions swirl in your mind, and you're not sure where to turn. A Rugged Journey is a safe place to ask your toughest questions. You can ask us anything, anonymously, and find solid advice on relationships, anxiety, addiction, self-worth, whatever you're struggling with. Our mentors are ordinary people, willing to join you on your journey in a compassionate and respectful way. The road can be long, but you don't have to walk it alone. A Rugged Journey.
Have you ever felt like you were nearing the point of being overwhelmed? Who hasn't experienced the feeling of burnout? From that place of being overwhelmed, have you felt there was nowhere to turn? As humans, we're very good at hiding the reality that at times we are way too close to our breaking point. In the midst of our overwhelm, we may even receive compliments that we've never seemed stronger, when in fact we really feel like we are breaking. What if there was a safe space where you could bring your brokenness and experience healing? Coming soon, you can engage in 12-step style groups to avoid succumbing to burnout. Be on fire. Avoid the burnout. Be not consumed.
Anxiety, relationships, addiction, self-worth. Where do you turn for answers to life's challenges? Gorgeous to God is a safe space for young women to ask their toughest questions and find their deepest purpose. Our mentors are ordinary people willing to journey with you in a compassionate and respectful way. You are loved. You are seen. You are gorgeous to God.
Most of us know where to go when our bodies are broken, but do we know where to go when our hearts are broken because of loss? At some point in our lives, we all experience the pain of loss and are in need of heart healing. When we lose someone or something important in our lives, it hurts. The hurt is called grief, and it calls out for relief, for comfort and some type of help. Where can we go? Where would you go? Health experts are predicting a pandemic wave of prolonged grief in the aftermath of COVID-19. We can be present for each other in both our joys and our sorrows. It takes a careful and understanding approach. Grief support groups can help. Your community, both in and out of your local church, is hurting. Watch for resources coming soon to help you more effectively lead others through the seasons of their grief. The mission of the Adventist learning community is to empower people with the passion and skills necessary to further the kingdom of Christ in the 21st century. Because of technology, we can put training, education, and resources into the palms of people's hands anywhere and anytime. Whether you're a pastor, teacher, church administrator, believer, or Christ seeker, you'll be able to find free courses that you can take for continuing education credit, certification, or just for fun. Our portfolio will help you manage and keep track of your continuing education units for pastors, teachers, and administrators, as well as student learning outcomes for pastoral interns. Our ministerial and educational library puts Adventist resources from around the world at your fingertips. Watch a video, read an article, and share what you find with others. Browse and connect with Adventist teachers that are looking to partner and create academic and faith-based learning projects. Search for project ideas that address real-world problems and create a solution. Follow the steps to guide your class through project-based learning and empower your students to take an active role in learning. Then, share your results. Explore our course catalog and see if there's a faith-based course you'd like to take or a resource you could use in your ministry or devotional life.
In the annals of human history, we behold a canvas of human triumphs and innovations, such as exploring space, the development of mobile technology, conquering air travel, and social movements that have led nations to choose virtue over victory or economic value. But we also behold human brokenness and woe, inherited from the fall of our first parents. A brokenness that extends beyond physical disease, war, or moral decay, but even into the individual mind. In the United States, 1 in 5 adults experiences mental illness, while 1 in every 25 experiences its effects so severely they cannot perform daily activities and require treatment to overcome. But this isn't simply a problem for adults. 70% of mental health problems begin in childhood, with over 7.7 million youth between the age of 6 and 17 experiencing a mental health disorder today. Canada reports that 50% of its citizens have or have had a mental illness by the age of 40, while also serving as the leading cause of disability and leading to 11 successful suicides per day. Even more alarming is that many reported being more willing to tell their friends they had diabetes or cancer than to share their struggle with mental illness. Early intervention is one key element to better outcomes, but the chasm of stigma is vast and difficult to cross. But on the wings of hope, such a stigma can be overcome, especially when we find hope to be more than a feeling, but a person, Jesus Christ. Jesus stated in Luke 4:18 that he was anointed to heal the brokenhearted. Jesus has anointed us with his Spirit to do the same for the brokenhearted of our day. This work we as his church have inherited as a legacy to continue his loving ministry to the whole soul. Built upon our view of what it means to be human, we can offer a more holistic framework for recovery to those fighting on the battlefield of mental health.
Welcome to the Restored Mental Health and Wellness Summit. Thank you for joining us. I'm John Rengifo, lead pastor at the Ellicott City Seventh-day Adventist Church in Ellicott City, Maryland.
And I'm Erica Jones, Assistant Director for Women's Ministries at the North American Division of Seventh-day Adventists. John, we have a full program over the next 4 days covering a broad range of topics related to mental health and wellness. As the pastor of a church, what is the significance of this topic for you?
Erica, the pandemic has brought about many challenges that have affected my own congregation and their families. Just to name a few, there are those who are grieving the loss of loved ones over the pandemic. I've had members who have lost jobs in the last couple of years. Students who have gotten behind in schoolwork because they didn't do well in virtual learning and lost touch with friends. And of course, there are those who are still facing some anxiety about getting close to people. And so that's just to name a few, some of the challenges we faced. Now, you're studying to be a counselor, right?
That's correct. I'm currently finishing up an internship at a mental health clinic where I'm seeing clients who I relate to what you just said about your congregants, because I'm seeing clients who are suffering from anxiety, depression, grief, loss, sometimes loss that they didn't even realize was affecting them until much later, and they're just now dealing with it. So yeah, the pandemic has really kind of unearthed a mental health crisis that I don't think we were aware of up until now. Yeah. Well, we are going to head into our event this morning. Like you said, it's called Restored. What do you think about the name of our summit?
I really appreciate the name Restored because it shows that it's not only a destination, but it is a process of an ongoing thing. When I think restored, I think of God's promise of what will soon be taking place, where we will all be once again restored to God's ideal image from the beginning. So I really appreciate this theme.
We want to turn to Dr. Angeline Brower, the Director for Health Ministries at North American Division Seventh-day Adventist, and find out more about how this summit came about.
Good morning, and thank you so much, Pastor John and Erica, for being with us and being our leads here on stage. It is a pleasure to be with you all here at a day that has been long looked for. I'm delighted to welcome each one of you, our live audience online. Thank you for joining us there. Our attendees, our speakers, our distinguished guests, thank you all for taking the time to come together to talk about this very important and pressing issue. We also have individuals joining us through our live stream, so welcome to you as well. This summit has been several years in the making. So even the theme Restored, as you were talking about, really went through several iterations in our name. So why did we come and settle on this theme? Well, truly, it is because this is a promise that comes directly from God's word. In Isaiah 58:12, it says, "Those from among you shall rebuild the old waste places. You shall raise up the foundations of many generations, and you shall be called the repairer of the breach and restorer of paths in which to dwell." So we need to remember, though, the context of this verse in Isaiah 58. This promise follows a very significant and relevant identification of what are the acts that come out of a heart that is connected and committed to serving God and serving others. The promise is framed with verse 10 that says, "And if you pour out that which you sustain your own life for the hungry and satisfy the need of the afflicted, then shall your light rise in darkness and your obscurity and gloom become like the noonday." So we are here to minister hope and healing. And we are here to see what the power of God can do in each of our own lives, because it is His power that creates and His power that restores. So the summit is only the start of this journey, and I hope that you stay with us through the course. So today and tomorrow, we will be having our educational sessions filled with our keynote presentations as well as concurrent seminars. We actually have 44 different concurrent seminars, all with different presentations, so you won't have duplication. That will be going on between today and tomorrow. But beginning Friday night and into Saturday, we want you to stay with us for our inspirational programming. I really have to put a plug for Friday evening's live stream event starting at 8 p.m. Eastern. And then on Sunday, this is going to make it very practical. We will have the hands-on practical trainings where you can gain skills that you can use in your local community, in your church, in your clinic, in your practice, wherever it's relevant. Every component of the program has been carefully prayed over by our planning team. I'm going to confess something to you. This event actually wasn't supposed to happen. at least in my mind. You see, there were many times when I felt the temptation and the discouragement to actually cancel the program. But just at those moments, and again, there were many of them, just at those moments, God sent someone who gave me a word of encouragement, who said, I'm so glad you're doing this. Thank you for doing this. We need to talk about this. We need to be here. So I want you to know that you are here, and this program is here because it was God's will. I want you to know that everything you receive that will bless your heart is from God. And I want you to know that when there are times of discouragement in your journey, that we are here to tell you this is the right thing to do. Keep going, keep pressing forward. So I hope that all of you will stay with us after this event as well, because you see, this is really just a launch of our long-term plan at a collaborative approach of addressing mental health and wellness. We are on a mission to restore hearts and minds, and we need to be on this mission together and for the long haul. So thank you for being here. I look forward to being with you throughout this journey.
Thank you, Dr. Angie. Thank you for those words. And now we are going to be blessed by just a message of encouragement from our North American Division President of the Seventh-day Adventist Church, Dr. G. Alex Bryant.
Greetings to all of you, and welcome to the North American Division Health Ministries Mental Health Summit of 2022. We're delighted that you could join us. I would like to thank our director, Dr. Angeline Brower, for her leadership in putting this conference together. And it's a wonderful time to come together and to talk about mental health and how we can best support those and provide ministry to those who are in need of mental awareness and how they can best be supported by the Seventh-day Adventist Church. Thank you for joining us, and thank you for your ministry that you are doing on a daily basis and the lives that you are touching and are being transformed after the life of Jesus Christ. We are delighted that you have joined us. I'm going to invite you to bow with me as we pray, as we open up this conference and our devotion today with a prayer. Bow your heads with me. Father in heaven, we thank you for the privilege and opportunity to come and to be a part of this tremendous health summit, this mental health summit for 2022. And I invite your presence to be with us and to hide the speaker behind the cross of Calvary as we open your word for a few moments to hear you speak to us is our prayer in Jesus' name. Amen. You know, as I think about this thing called health ministries, and particularly mental health, I think about our God, and I think about God's intent for his people and for his children. And you know, the heart of God is a heart of compassion, and God looks for ways to reveal his heart to those of his children who still don't know him, and even to those that know him. God is always at work trying to find ways to reveal his heart to his children. And so I think that this subject on mental health is a way for us to look not only in the mind of God, but to look in the heart of God, that God cares. There's a text in the Bible over in 3rd epistle of John, verse 2, and what God says, I wish above all things that you prosper and be in good health, even as your soul prospers. And what God is saying is the rest of your health is as important to me as your spiritual health. Your physical health and your mental health and your emotional health, God says, is as important to me as your spiritual health. And I wish above all things that you would be in health, that your soul would prosper, just as your physical body prospers. You know, when you think about the heart of God, and when Jesus came to this earth, Jesus came and when he began his public ministry, he says, the Spirit of the Lord is upon me because the Lord hath anointed me to preach the good tidings unto the meek. He has sent me to bind up the brokenhearted, to proclaim liberty to the captives, and the opening of the prison to them that are bound, to proclaim the acceptable year of the Lord and the day of vengeance of our God, to comfort all that mourn, to comfort all that mourn. You see in this language of Jesus, when Jesus was beginning his public ministry, he said, let me tell you what I came here to do. Let me tell you what my Father has sent me to do. Let me tell you what the Spirit of God has empowered me to do. He's empowered me. He's anointed me, is what Jesus is saying, to heal the brokenhearted, to speak a word of encouragement. And if you look at the language of Jesus, it really can be summed up as I have come so that your health will be uplifted, so your minds would be uplifted. He said, I have come to speak a word of encouragement to those and to bring healing to those who are brokenhearted. And as you look at his life, if you look at the totality of his life and the work that he did, the Bible says, for God so loved the world that he gave his only begotten Son, that whosoever believeth in him should not perish but have everlasting life. It is God's, Jesus, the coming of Jesus is the expression of God to the world of his heart. And when you look at the work that Jesus did, it is a revealing of the heart of God. And I look at health ministry, and I look at trying to help people become whole as God wants them to be whole. It is a revealing of the heart of God, because God says, I wish above everything that you'll be in good health and that your health will prosper. And it is God's desire for us to be whole and complete. And God says, I want you to reveal my heart to others. And I do that through healing them. I do that through helping them. And when we look at the life of Christ, the life of Christ is the expression of the heart of God. And you know, one thing about God, the first thing is that the health ministry is designed and built to reveal the heart of God. And when you look at the life of Christ, you see health ministry lived out in the life of Jesus Christ. There's a couple of incidents that come to mind. Jairus and his daughter was ill and sick. And he went to get Jesus, and he was a rich person. He had a lot of money, and he had a high position and well respected in the community. And when he came to Jesus and said, listen, I need you to go because my daughter is ill, and my child is sick, and I need you to heal her. And Jesus was on his way. And that's what I'm saying. And what I like about Jesus, he didn't give him a litmus test. He didn't ask him about how good of a Christian he was. He didn't ask him about how well was he keeping the Sabbath. He didn't ask him about how was his health message, how was he living out the health message. He didn't ask him about anything, but because he was in need, Jesus said, I will go and I will speak to your need. And so he started moving toward his home and to go to minister to his child. And things were going a little slow because the crowd was around Jesus. And while Jesus was on his way to help Jairus' family, he gets interrupted by somebody else who needed him. We call it the woman that came to him And the Bible doesn't give us his name, her name. With Jairus, he was rich. He was wealthy. He was well-to-do. He was well-positioned. He was well-known. But this person didn't have the stature. First of all, she was a woman. And in that culture, women were looked at as second-class citizens. And then she did not have position. It doesn't tell us who she was. It doesn't give us her name. It doesn't give us her status. It doesn't say anything about her. And Jairus came to Jesus eyeball to eyeball and said, would you come and help me? And Jesus responded and said, yes. But this woman, because of her stature, because of her status, because of the fact that she was not well positioned in Israel, because she was not well known and well thought of, she said, listen, I don't have the same position to go to Jesus as did Jairus, and I don't really need that position. She said, listen, I'm not going to even try to interrupt him. I'm not going to try to stop him. I'm not going to try to get in his way. She said, but if I can just get close enough to touch the hem of his garment, then I'll be made whole. And the Bible says she got close enough and she touched the hem of his garment. And she said, I got what I came for. Without any fanfare. And she went to walk away. But Jesus says, somebody touched me. You know, to everybody else, she was a nobody, but to Jesus, she was a somebody. She, even to herself, said, I don't have status, I don't have position. And she said, I don't have any insurance, and I've spent all my money, I don't have anything to offer him, but all I want to do is get close. What I'm here to say to you today, my brothers and my sisters, God is no respecter of persons. And God uses health ministry to heal people no matter what their position, no matter what their status, no matter what their background, no matter what got them in the situation that they're in. God doesn't give litmus tests. God says, I'm going to meet you where you are, and I'm going to touch you where you are. And that was the heart of God. That was the message of Jesus. That was the method of Christ. And that's what made Jesus so popular. You know, we forget. We think that when Jesus came here, everybody just hopped on board. No, Jesus, when he came, remember when he came, he was not a favorite of the government. He did not have government status. He didn't even have status among the religious leaders. Jesus earned his stripes as a leader because he was where the people were. He met the people where they were. He went from community to community, and you know, the method that he most used was healing. He ministered to people where they were. And many people were like this woman who was like Jairus' daughter. They were in need of healing. And Jesus went from community to community and he healed them. And one of the things that Jesus did for everybody, when you were around Jesus, he lifted the spirit of all. He used his influence. He used his position. He used his status to bring healing to everyone. And you know, one of the things that Jesus always did, if you would go through the Bible and especially go through the Gospels, when Jesus showed up, he first spoke to people's state of mind. Remember when the disciples were out on the water and they were fearful and they were afraid? Jesus says, wait, I want to speak to your mind. I want to bring healing to your mind. I want to slow things down in your mind. I want to restore your mind. He says, I want to bring you to complete wholeness. And that's what made Jesus so popular. It's because Jesus was known in the community that he revealed the heart of God. He was known in the community that he was not a respecter of persons. He saw everyone, or he respected everyone as children of God. And as that word got around the community, that when you come to Jesus, if you can find your way to Jesus, if you can get to Jesus, he will heal you from whatever that ails you. And guess what? He doesn't give you a litmus test for healing. He heals you because you're in need of healing. He heals you because you are hurting. He heals you because you are suffering. And I want you to know, when you've been healed by somebody, you want more. I remember going to a particular place, I'm not going to mention where it was, when I first moved to this area, and everyone told me, don't go to such and such a place. Don't go to this hospital. They don't provide good service. But something happened. I was in pain. I actually had kidney stones. But I had to go. And those people, when I went there, they gave me some medication. I can't remember today what it was. But I want you to know it made me feel good from the crown of my head to the sole of my feet. And it made me think differently about that place because they did something for me. And what I'm saying, Jesus used health ministries. He used healing as a way to people's heart, because when people are in need, especially physical needs or mental needs, their hearts are open for more. And Jesus says, listen, I'm going to first just meet you where you are. I will heal you where you are, just because you're in need of healing. And because Jesus healed people where they were, then they came back for more. They came back to hear his teaching. They came back when he went to the mountain. They were in the group of 5,000, but it started with the work that Jesus did in a community of healing and lifting people's spirit and healing them physically and healing them mentally. That is the formula that God is calling his church to use today, and is a formula that still works. Let us pray. Father, help us to be like Jesus, to reveal the heart of God as a heart of compassion. Help us to be like Jesus, to show people that you love them with an everlasting love. Help us to be like Jesus, that we respect all people as children, sons and daughters of God. And help us to be his hands and his feet. And give us the wisdom and the knowledge to share so that the people in our communities might see your heart and might be healed of physical and mental ailments and might be made whole as you want them to be whole. Thank you for hearing us and being with us during this conference. It's our prayer in Jesus' name. Amen.
Thank you, and welcome back. We have, Erica, our first keynote presenter of the summit. What can you tell us about her?
Well, our keynote presenter is Dr. Anita Everett. She is currently the director of the Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. That is part of the U.S. Department of Health and Human Services. Prior to her arrival at SAMHSA, she served as the section chief of the Johns Hopkins Bayview Community and General Psychiatry in Baltimore, Maryland. She was on the faculty of the Johns Hopkins School of Medicine and the Bloomberg School of Public Health. At Hopkins, she directed 22 community psychiatry programs that provide a range of services to individuals from preschool age to older adults through a range of programs that include acute services as well as recovery support for persons with serious mental illness. So, Dr. Everett, welcome.
I want to thank the hosts for inviting me to come and talk today. We in the federal government, and in particular the agency where I work, the Substance Abuse and Mental Health Services Administration, SAMHSA, are very grateful to the partnership that we have. Many of our grantees throughout the nation and many of the individuals that work in the mental health field have with faith-based members. We know by and large that individuals who are involved and active in faith-based communities are traditionally more giving of their time, and that also applies to sharing and working with individuals who have mental health, various forms of mental health crises and conditions. So at the outset, I'll say I'm very grateful and very interested in doing whatever I can to support those efforts. I brought with me some slides, which I'd like to share. And so I'll move into that. Thank you. All right, so my role, as has been introduced, is I'm the director of a part of SAMHSA called the Center for Mental Health Services. What I want to do today is begin with a bit of a case story. I want to tell you about two brothers in the same family, one called Jake and one called Quentin. And these brothers are in high school. Jake's a soccer guy and Quentin is the student, the studious one of the pair of brothers. Jake is out in the soccer field one day and he has a sports injury and he falls to the ground. And I want us to sort of think about, those of us who are soccer parents, what happens on the field when Jake has an injury. In the games that my children played in, the play stops. All the other players are aware of what's happened. They sit down. Parents and or coach go over to assess sort of what's going on. They have basic knowledge about what could happen to Jake. They're sort of assessing for, can he get back up? Is something broken? They have basic sort of first aid knowledge that they have. They make a decision. It looks like Jake needs an intervention. So one of the parents has a cell phone on the field. They call 911. And we all kind of, the other parents on the field, sort of know what's going to happen. An ambulance comes, takes Jake to the emergency department where he's greeted by professionals who are familiar with assessment and stabilization of his injury, sports injury. And there may or may not be a specialist involved depending on the situation. That's Jake's situation. Now I want to move to his brother, Quentin. Quentin's the studious one. He's a senior and looking at applications for college. Many of his friends have gotten early decision acceptance letters, and Quentin has not. And he's increasingly irritable at home. One day, the teachers call the parents and say, we're worried about Quentin. He's written an essay for English that's pretty down. It's pretty, it talks about reasons for living and not having reasons for living. And it was concerning to the English teachers. The parents go up, knock on Quentin's door, and he doesn't want to let them in. He says he's just doesn't feel like talking to anybody. Would they please go away? They knock again. Quentin opens the door. Quentin is sitting at his computer. He's crying. He's upset. And they notice on the bed is a noose that's been fashioned from a climbing rope that the dad had in the garage. And they're very worried about Quentin. It's a dramatic story, but I want to ask you to think about what in your community these parents would do if that were the situation that they found Quentin in. Could they call 911? Would that be appropriate? Would they get him in the car themselves to take him to an emergency department? When he gets to the emergency department, is he going to be greeted by individuals who are skilled and knowledgeable about the treatment of mental illnesses? What if Quentin refuses? Are there emergency, what happens to Quentin? He's in acute mental health distress. I'm going to now switch gears and talk a little bit about some of the programs and things that are happening in the world, but we're going to come back and see what happens to Jake and Quentin at the end. But I do want us to sort of, meant this to be a bit of a springboard, so we kind of are thinking about how are our communities, how are our safety nets set up to work with mental health crises. We're pretty good with regards to health crises. How are we doing with regards to mental health crises? Okay, so what I want to cover today is to talk a little bit about, let's move this slide forward. Mental health in the COVID era that we're in right now. Talk a little bit about some of the programs that we have that are currently new that I think are we really want everyone across our country to know about. And also partnerships and community supports and the value of those in assuring individuals with mental conditions are in the context that they are in, that's supportive and helps them, those that need professional care, get into those settings. So in general, we are a society under stress. All of us have been stressed by the presence of COVID over the last over 2 years now. Who could believe that? These are some of the markers in recent media that indicate the stress that we're all under. Violence on airplane flights, psychological distress has increased among school-age children since the pandemic began. We see a number of people who are involved in this phenomenon that health economists have called the Great Resignation. And we think some of the individuals who are leaving fields like nursing and also behavioral health fields are doing so because they're burned out at the demands that have been placed on them because of COVID, but also because they're in a period where they're reassessing their life values and reassessing what's important to them. I'm sure that comes up in the context of ministries and faith-based communities, because that is often another place where there are answers to meaning in life. And that is what we know that a number of individuals are experiencing, these 4 million individuals who left their jobs over the last several months. And then we're also seeing, increasing violence in our society and concerned about that. The CDC, our partner, one of the other agencies in the Health and Human Services family of agencies, the Center for Disease Control and Prevention, has started doing since the pandemic a series of surveys that they call a pulse survey. And that is where some of the information has come from that tells us that we have some real data on the increase in anxiety and depression in our world. And so these are telephone interviews that are done every several months and operated again by the CDC. But what you see here on this map is a map of the United States. And the darker green shows a dramatically increased incidence of reports of increased anxiety since the onset of COVID and just living in the era of COVID. So not necessarily people that are impacted or infected by COVID, but living in the era, all of us that live in the era of COVID. In a similar kind of way, the CDC has also demonstrated increase in depression disorders in these states. It's a slightly different grouping of states, but the pattern is the same. The dark states are the ones that are much more likely to have signs of depression that are associated with the COVID era that we're living in. Dramatic increases. Here we see also, this is a slide that has a little bit of data on it that indicates that the number of adjustments that have been made in the healthcare field. So we know that many, not everyone that has any kind of mild anxiety necessarily needs formalized specialty treatment, but many individuals do. And there have been some changes in that that include having appointments moved. That's the dark blue line there. Having delays or cancellation in appointments. 38% of people who needed treatment received that, so a third. And then also delays in getting prescriptions or disruptions in normal care. And there's the red marker there. And then unable to access needed care, resulting in moderate to severe impact on their health has also occurred. So these are all sort of indicators of disruptions. Want to have just a little bit of an insight or sort of take a little bit of a sidebar to remind us all of the additional burden that has occurred for individuals that are members of communities of color. Black Americans comprise 13% of the total US population, yet they have to do with 30% of the COVID cases. And so almost a double of what would otherwise be expected. Black individuals have experienced a disproportionate share of COVID itself. Latinos actually are about the same. So they currently make up about 18% of the entire US population. And in that same neighborhood are about 17% of COVID cases. And so not as disproportionately impacted as Blacks have been. COVID itself has revealed deep-seated inequities in access to and the quality of healthcare, particularly for communities of color. Basic common sense health literacy is a problem throughout America, and especially in communities of color. Health literacy is the notion of sort of knowing what to do about mental illnesses and having a general sense of what mental illnesses are. Part of the story of Jake and Quentin is that, you know, the parents that came out to the field have a basic health literacy about what should happen with someone who has a possible fracture as a sports injury. There's not as much health literacy for the same parents in the situation of Quentin, who's acutely suicidal, but they don't know what to do or how to assess what's going on with him. And then, so next I want to sort of move into talking just a little bit about some of the programs that we have at SAMHSA. And this is a group of federal bureaucrats that are, you know, who you hire. We work for you, the United States government, the partners in Canada. We don't work with you, for you directly, but we certainly work with our Canadian partners and know that we have similar problems and are designing several similar solutions in many ways. The current priorities that have been outlined in the mental health agenda led by this administration include capacity building. This is in recognition of the longstanding difficulty we have with sufficient capacity to meet the needs or meet the demands on mental health services, connecting individuals to good care, so there's a tighter connection with available resources, and also a sense of community, a sense of healthy communities that support emotional well-being of individuals for all of us there. So those three sort of main categories are how we're currently organizing a lot of our activities within the government, all important issues to address. SAMHSA itself, and then more particularly my center, we're an agency that serves individuals with mental illness and emotional disturbance through promotion, prevention, and treatment. So we have primarily the way we do our work is through administration of different grants. We have multiple different grant series that we work on, and they're sort of one way to think about them is they're organized around these three basic sort of styles of intervention or populations. So now I want to talk just a little bit about one of our programs that we're actively working on right now, and that is the crisis services, the development of national crisis services. And so again, I'll sort of call on Quentin, or the situation that Quentin and his parents find themselves in. What does a person in crisis need? So they need someone to talk to. They need someone to respond if that situation is called for, if there needs to be a response in person, and or they need a place to go, which can be, you know, an emergency department, crisis receiving centers, which we're seeing increasing growth of throughout our country, and they need some degree of follow-up. But really the way we frame this is someone to talk to, someone to respond, and a place to go. Either one of those three options, which in the United States, we have pretty well accomplished with the 911 response and possible things that could happen when you call 911. And we have not developed that as it should be or as it will be over time with the emergency crisis and mental health response system. These are some of the elements that we think are important that respond to or are designed to respond to those three elements. So on the left there, we have the person in crisis. Our vision for how a built-out crisis services system will occur is to have crisis number, which is available nationally. Right now, SAMHSA itself, the Center for Mental Health Services, operates a line called the National Suicide Prevention Lifeline. And hopefully those of you who think about and work with individuals in mental health crises or at risk for mental health crises have some knowledge of our longstanding National Suicide Prevention Lifeline, or sometimes we just call it the Lifeline. What is now available through that service by dialing that 1-800-273-TALK number will be universally available after July by dialing 988 from every cell phone and every landline across the entire United States. This is a movement that is also occurring internationally. So what that means is if you're in a situation like Jake's parents, say for instance, and Quentin's parents, that would be an option for you is to call 988 and to work with the individual on the other line there after July. It turns out in systems that have this fairly mature, and Arizona is an example of a state that has a fairly mature crisis response system, they've learned that 80% of the situations at hand can be fairly readily resolved with planning in place by a phone call. Sometimes that's, some systems in some states are very sophisticated at this point in time. In Georgia, for instance, Georgia has a thing called the Georgia Crisis Access Line, Gcal, that's statewide. When you call that line, they actually have the capacity to connect you to an available inpatient bed if that's needed, or an outpatient appointment or a clinic that can receive you. So that's sort of part of our vision. But we've learned that many crises can be resolved with a plan, with a call. For those who can't be resolved that way, or there's a more imminent risk involved, we know a first responder is often called for. Too often in our world these days, and certainly it's on the media quite often, where there's a response by a first responder would be law enforcement. Law enforcement do their best. They're well trained in many things, but by and large, mental health responses are not necessarily what they're trained to do or what they go into law enforcement to engage with. And so our vision for how this would work would be that there'd be trained individuals that come from a mobile crisis team that are able to be dispatched to respond in person. So the situation of Jake, for instance, the mother calls, she's very upset and distressed while the dad stays with Quentin, and they call 988. And there's an individual not in an unmarked car that could come. If there's guns or weapons involved, many of the communities that are setting these up do have law enforcement available to come or not. There's different models for how communities are working that out, but the notion is to have someone that can respond that's not solely law enforcement with the big flashing lights and the big way that law enforcement is involved, as should be for the situations that they're involved with. Turns out that when mobile crisis people respond in the systems that study this, upwards of 70% of those can be resolved in the here and now with some follow-up scheduled and follow-up calls and things like that, but those situations can be resolved. So in those situations, that means the person doesn't need to go spend the weekend in an emergency room waiting for mental health bed or something like that. The next step that we're envisioning, and as many communities as have capacity to do it, is to develop specialized crisis receiving facilities that serve as alternatives to emergency departments. Emergency departments are great. We're very dependent on them and appreciative of all the work that happens by emergency responders. But we also know that many emergency room staffs don't feel comfortable with or aren't prepared well with working with individuals in mental health crises. And so many communities are starting to look at and set up alternatives to emergency room departments, which have trained staff that can diagnose, initiate treatment, and stabilize an individual well enough that they don't need psychiatric hospitalization. They can go back to their community and have a follow-up if they need follow-up. And so that's a model that's working really well. So there we have the three main things: someone to talk to, someone to respond, and a place to go. Let's see. This is just a sort of a slide that is a reminder that the National Suicide Prevention Lifeline is what will become 988 after July. This is going to be happening all across the United States. The Suicide Lifeline number, if you still have any of those old refrigerator magnets or posted the suicide number, that will still be intact. So that'll still be viable. But you also can much more easily remember 988 as a way to dial to connect into mental health services. And this is just a listing of the different structures of this, but we've invested quite a bit of money to build and strengthen this call center as a safety net that has a good working knowledge of the local community as to the extent that it can. Changing gears just a little bit, I also want to talk a little bit about some of the programming that we've developed and have access to with regards to our nation's children. So I think, many of us are concerned about that. We read in the paper or know about the impact that COVID has had on children themselves. We know that school has been very disrupted for many school systems, virtually all school systems to some degree over time. And we know that kids themselves have been under a huge amount of stress just from that factor alone. The school in and out, all the things that go along with what it means to be in and out of school with peers for a week or two, then not with peers, all the different ways that kids learn how to socialize and troubleshoot and solve problems together with their friends, work in groups in classrooms and things like that. All that's been grossly disrupted. On top of that, for the kids, I think we're also learning as increasing numbers of kids are returning that we've lost some time with the academics of many of the kids, which adds to the stress that the kids and the parents are experiencing. Maybe they were in third grade, but really they aren't the equivalent of being able to move on to fourth grade because really the third grade was almost a wash. And we as a nation are, really working on how to solve that. But the impact on the kids and families has been a tremendous amount of stress. We do have multiple programs at SAMHSA that are designed to sort of work on those, the details of which I won't go into, but there's a couple principles here that I think are important. One is manifested by the systems of care diagram that's on the upper left corner there. And what that is, it serves as a reminder of is that kids are involved in a lot of different systems, particularly kids that are troubled or have gotten into trouble before. And so having a community or having resources that involve these different systems so they work together for the child is very important. This concept of care coordination across. So if you have a kid that's involved with social services, a foster kid, for instance, they also are going to have education needs and other sets of needs that are best serve the child when they work together. There is a federal website that's been created, this Find Resources to Create a Safer School, schoolsafety.gov, that has in it a number of different resources that are designed to be, it's helpful for the general public. So they are submissions of successful programs that have been put in from school systems all across the country. And there's a whole section there on behavioral health and the strategies that schools have used that help to sort of support the social and emotional growth and development and success of children. And the last thing I'll land on with regards to this slide is the triangle there, which demonstrates sort of a good old-fashioned public health approach that we encourage schools to take on. And that is tier one, sort of developing a culture in a school, an environment that fosters healthy social and emotional learning for all the kids that are in the school. Second tier is having a system that identifies kids at particular risk. Maybe a kid, there's knowledge that a child's parents have lost their jobs because of COVID, and that adds extra stress to the family. So that kid who may or may not have a mental illness is undeniably at increased risk for stress and other factors that would anxiety, those kinds of things that might show up in a classroom. And then our system, our desired system, this multi-tiered system, also has at the top tier encouraging school systems to develop ways to have resources for kids who actually do need specialty treatment there. I also just have that one other slide or one other sort of reference there to mobile crisis, just to remind me to remind everybody that the 988 system, as is the case with the National Suicide Prevention Lifeline now, the Lifeline call, is available for crises that children experience as well. So it's not just only grownups, but it's children as well. So back to our case study, for instance, Quentin's parents in that situation could call 988 or access 988. One other program that I want to talk just a little bit about is that is in a number of states. Not all states have this program right now, but I do want to talk about it just a little bit. And you see there at the top right corner, the map of the United States. This is the states that have prominent development of these services. What these are is a particular collection of services that are put together in a community mental health center style of services that are called CCBHCs. I know many of you are active in advocacy work and things like that. A number of our senators and representatives at the national level are very supportive of the development of and funding for the CCBHC model. It has in it many elements that are very important in managing both short-term illnesses as well as long-term mental illnesses. It has in it requirement for crisis services. And so the services that would come out, the mobile services and or the crisis receiving style services, access to clinicians 24 hours a day is a required component of the CCBHC model. Another required component that has to do with access is that they're required to have no more than 10 days between the first call and the first face-to-face appointment with a clinician. And so they really work to increase access. It's a model that we've gotten quite a bit of funding from, both from Congress, from the last 2 administrations that we've had, and a number of the COVID-related funds have gone to support these particular style of community mental health services. Most communities across the country have some form of a CCBHC, but not the complete set. And we're really advocating for the complete set of services to help get people what they need. My way of thinking about it is, if you had a brother who had schizophrenia, this is the kind of clinic you'd want him to go to. If you had a nephew who had depression, this is the kind of clinic you'd want him to go to, because it is a kind of a one-stop shop. All right, so what we've learned as a result of the pandemic. There's several important lessons that we've learned here from the pandemic or in the era that we're in. One thing is remote work can work. And so we've learned that remote clinic visits can work. This has been tremendous, particularly for rural communities who didn't have access to specialists because the specialists would have to drive 3 hours to get to a site in the past. But now we know through telemedicine, through venues like what I'm coming to you through today, we actually, psychotherapy and many types of interventions that mental health providers do can work very well. In fact, I've had some of my own patients tell me they like this kind of style better because they don't have to transport into the clinic. And it's a little less anxiety provoking to go through all of those things. And so they're more comfortable. They're in their home environment. They feel like sometimes they can be more open and honest about things. There are some, issues with regards to telemedicine, but for many, it works really well. I've gotten to meet people's pets that I hadn't had the opportunity to meet before, and find out they're part of their lives, an important part of the framework. I think we've also learned that public health and health delivery is important in our culture. I mean, we see that sort of nationally with some of the thought leaders that we think about today, or maybe we, in today's language, we'll call them influencers. Public health and health delivery is important. We also have the notion that health literacy matters. I think that's an important take home. Health literacy, of course, in our field for mental health, we want everyone to have more working knowledge of what is, what constitutes a mental health situation, what is, what are mental health conditions that can have crises and need follow-up care and need support moving forward. But it also matters in terms of what our understanding is about, many health conditions and how they can often, when we have a general health condition and it mixes in with a mental health condition, that can make things actually worse. I think we've also learned at at an individual level, each one of us has sort of grappled with what it's like to be alone more than we were probably before. So we have this concept of autonomy versus a sense of community and belonging. And how does that work for us? And where do we thrive? Some combination of alone time and social time is probably where we want to be. But we've had a reset with regards to COVID and the forced isolation that we've had. And as we're emerging, I think many of us are sort of recalibrating that sort of dynamic. And then we also are seeing sort of a role for government. We've all seen, as COVID, different ways that COVID's been managed. And I think, if you asked 100 men on the street or 100 people on the street, I think no one would say they necessarily wanted bigger government. But I think we've learned that government has an important role, and we want to have better government that serves us well. And we want to partner. We want to have government partner well at the federal, local, and state level, partner well with supports in the community, such as individuals that are active in a faith-based community. That's a very important component. So faith-based communities themselves are very much some of our best friends at SAMHSA. We value tremendously the work that can be done by faith-based communities, both at the individual level and also at the group, at the larger level with the congregations and messages and things like that. Faith-based communities can have a really important role by reducing the stigma. one of my favorite scenarios on that is I have one of the clinic populations that I worked with in the past is kids with special needs. And I remember how grateful I was that to the parents that told me that they take I ask them, do they get anxious when you go out in public with them, or can they do that? And they're talking about how receptive the faith community was with that they participated in, because this person had irresistible yelling every once in a while. And so the faith community adapted to this individual. They had a way that they sat him on the back pew, and he would come in and occasionally, yell out that they knew that was going to happen, and it happened. If it got to be bad, but too disruptive for the congregation, they would, take the individual out until he settled back down and bring him back in. But they developed a way to sort of work with him that was so accepting. It was really grateful. He developed the job of putting the mailers in the pews. That was part of his job as well after Mass. And it was really a beautiful example of stigma and acceptance, a model of acceptance across the community. We know faith-based communities are often involved in community partnerships and different ministries, visiting ministries and things like that. One of the things that we think about sometimes in mental health is like we want our illnesses to make sure they're casserole illnesses. So, someone's sick with cancer or undergoing treatment. It's common for neighborhoods or congregations to organize meal servings. Sometimes when mental health breakouts happen or a person has that, there's a tendency to move away rather than toward the person. And so remembering to include someone who's had a mental health hospitalization or something like that is an important part of support that a community can provide. I also think just basic health literacy is important, and we see that a lot in faith-based communities with different ministers themselves, faith-based leaders that are interested in learning about that. Of course, the situation that we might think of with Quentin, to get back to our case study with Quentin in his room, suicidal, certain families would think first of going to their minister and or a friend through church that they knew to reach out for a sense of what should we do next, or how can you help us, that kind of thing. So I want to finish up by telling you a little bit about the good news about what happened with Jake and Quentin. So it turns out Jake did have a fracture. He did need the services of an orthopedic surgeon. They reset his fracture. He's on a boot. He's only in his sophomore year in high school. So he was, the type of kid that they were projecting might get scholarships and things like that. So it was to colleges. So it was very important for him and also for his parents to play. But it looks like he's going to heal and get back on the field again. When we last left Quentin, he was in distress in his room. Again, sort of with some idea that the parents were terrified about, that he might be thinking about hanging himself. He's tearful. His parents are tearful. They're scared. They don't know what's going on. Luckily, the mother called her sister, and the sister had heard about 988 in their community, and the sister encouraged them to call 988. They did. They talked with Quentin on the phone. The situation got better. They gave him the name of a clinic where he could go for assessment. What happened, which is not unusual in the adolescent population, is he felt better after that conversation, and the week came for the appointment, and he refused to go. So the parents were very upset about that, but they said, well, it seems like he's better and we won't push it for now. Another week went by, something happened at school. Another friend found out he got accepted to college, and Quentin still hadn't heard anything. And the same situation came up again. This time Quentin's tearful, but he says, Mom, I think we better call the 988 people again and see if we can get that appointment. They call 988, the appointment was made. He goes to the clinic. He likes the therapist. He has 6 sessions with the therapist. He's doing really well, feels like he's ready to go. And he's in sort of recovery. He's doing well. His symptoms are gone. He's developed some skills through the therapy that help him manage it. He's gone on to university. And when he gets to university, he was accepted at the college of his choice, not in an early decision process, but a little bit later. He got in, and he works with he runs into a little scuffle with his stress about his first round of exams at college, and is able to identify a need and goes to the mental health counselor on campus because he's had such good experience with mental health, with access to quality mental health providers. And he's able to move on in his life and understand the value in use of access to professionals. His family was very relieved, and it was a situation that was resolved that very clearly could have gone another way if other interventions had happened. And that, of course, is, anyway, so those are some of the things I was going to say, just by way of reminder, that the Quentin and Jake they are examples of excerpts from stories from real situations, but they themselves are not a real family. They're made up names to protect the story itself. So what we've covered today, I hope that I've brought some things that are useful. When I put together talks like this, one of my goals is to have everyone that by the end of the talk have some news they can use, some useful information. So what we've covered today is a little bit broadly about the impact of COVID itself. It has affected all of us. If you're feeling a little more anxious, a little more down, a little more vulnerable, you're not alone. Our entire population has experienced increases in anxiety, depression. For the most part, we believe that's going to resolve for many people, but it may not for other people. And so we're working on that as we move forward in our adapting to COVID. You've been exposed to this model, the CCBHC model, which is an idealized, it's a good group of services that we'd want to see community mental health centers across our nation have. And it's very interesting right now and popular. It solves so many problems that congressmen and our elected officials and policymakers come against on a daily basis from constituents. We really love the CCBHC model and would like to see it everywhere across the United States. We've also talked a little bit about crisis services and how we hope to see that built out over the next several years. And we hope that you're a part of that together with us. It took nearly 60 years for the system of 911 that we have now to develop, and we know we're not going to do that. We're not going to be able to develop a mental health crisis response system in just a year or just 2 years. It's going to take a while, but hopefully we will be in a situation where, like what happened with Jake on the soccer field, that will also be able to happen with Quentin in his room. The parents will know what to do. They'll have health literacy. They'll know they can call 988. They'll know how to help when 988 is called, and they'll be able to have some assessment about what's needed to move forward, because they'll be a little more behavioral health literate. And faith-based communities are very good about helping with that. We've talked a little bit about suicide-specific services and also school-based services. And that concludes what I brought to talk with you about today. I want to thank you very much for your time and attention and for thinking of us to invite us to be part of your conference. And go forth and do good work, as I know you do. Thank you very much.
Thank you so much, Dr. Everett, for your presentation and for demonstrating and giving us some of that evidence that indicates how important it is that faith communities and really all the community resources around us engage together in addressing the mental health crisis, the mental health need, and also for promoting mental wellness and mental wholeness. So today I've already shared with you the foundation of why we're here and what drives us through the verses found in Isaiah 58. But I want to give you a little bit more of that foundation that will inform how we are approaching mental health and wellness from the North American Division, because this is what we need for our journey from here on. Prior to my current role, I had the wonderful privilege of working on the beautiful island of Guam. And this is a picture that I actually took of one of the sunsets, and every single sunset was different. It was absolutely stunning to be there. But even more beautiful than the scenery was the welcoming and hospitable individuals who lived there. I especially fondly remember my patients who were just so embracing and giving of what they had. But I also have not forgotten the challenges that they faced, the lack of resources, but also the great deal of mental need that is there on Guam. So let's take a look at some of those statistics. These numbers are from a few years ago, and I'm doing that intentionally because I know that the pandemic and really the past 2 or 3 years we've seen so much more of this unearthed, but this was still there. These issues were still underlying the lives and livelihood of people around the world. So here's what substance abuse looked like on Guam from a few years ago. 31% of adults smoked tobacco. 63% of them said that they wanted to quit, and 77% of them had tried. So we see the struggle, we see the need. And in fact, some of them, many of them, started at very young ages. I remember one of my patients who had started smoking at the age of 12. The prevalence of heavy drinking is similar to what we had in the US around that time. 32% of adults report ever using marijuana. And among the majority of those who reported it, the first use was when they were 13 to 17 years of age. And 5% of them report a lifetime use of methamphetamine and 4% of other illicit drugs. We also see that suicide rates on Guam were quite significant. In the United States in 2012, we have an estimate of 12 in 100,000 suicides and mortality rate. But in Guam, the estimate was 15.6 out of 100,000. Suicide on Guam was the 5th leading cause of death, with approximately 1 suicide death every 2 weeks. Now, Guam is a fairly small island, so this is really a large part of their existence and what life is there. The greatest number of suicides occurred among 20 to 29-year-olds. Sexual violence on Guam was also a major issue. In the US, where 9.4% of individuals reported that their boyfriend or girlfriend had hit them, in Guam, it was 15%, nearly double. And students who were forced to have sex in the US, 8%, while in Guam, 10.7, almost 11%. So we see that violence and agony and pain was quite prevalent there. Now, here in the United States, the message that we have been sounding over and over again is that you are not alone. And this is really an important message to share. 1 in 5 adults experience mental illness during any given 12-month period, and 1 in 25 experience a serious mental illness, which means that they are unable to do their daily activities. And 17% of our young people, this is age 6 to 17 years, experience a mental health disorder. If you look at the numbers that are listed there on the screen of the millions of individuals that this impacts, we see that this is an important factor. This is an important need. If we look a little closer over the timeline of the experience of different mental health illnesses in the United States, we see that the rates have remained fairly similar, but we do see that there are some shiftings in the age groups. The different colors there represent different age groups, and we see that there's actually among young people, the age of 26 to 49, they are going up. And among the young adults, age 18 to 25, since 2016, that number has jumped up to over 26%. So that's 1 in 4 of our young adults experiencing a mental illness. What about Canada? Here we have the percentage of Canadians by age group who report having been diagnosed by a health professional of having a mood disorder, such as depression, bipolar mania, etc. We also see, if we look at mental illness in Canada in general, we see that 50%, or 1 in 2 people, 1 in 2 Canadians will have a mental illness by the age of 40. The majority of mental health problems begin in childhood, 70%. It is a leading cause of disability, and nearly 11 deaths by suicide each day in Canada. And again, these numbers are from a few years ago. However, only 50% of Canadians would tell their friends that they have a mental illness. If you compare that to the number who would tell their friends if they had cancer, that's 72%, or if they had diabetes, 68%, we see that there's a discrepancy even in the willingness to share about what they are struggling with. And so this must bring to our mind the issue with stigma. Dr. David Satcher made this statement a few years ago. He was the Surgeon General of the United States, the 16th Surgeon General of the United States, and this is what he shares about stigma. Stigma erodes confidence that mental disorders are valid, treatable health conditions. It leads people to avoid socializing, employing, or working with, or renting to, or living near persons who have a mental disorder. A consequent inability or failure to obtain treatment reinforces destructive patterns of low self-esteem, isolation, and hopelessness. Stigma tragically deprives people of their dignity and interferes with their full participation in society. It must be overcome. In her book, Troubled Minds, Mental Illness and the Church's Mission, Amy Simpson shares that 45% of church pastors report that they are approached for help regarding a mental illness each year. Another 33% say that at least 6 times a year they are approached. These are our church pastors. So what this tells us is that individuals are looking to the church for help. Here's some data that helps us see some of that need as well. Let's look at Guam again. Here's a research study from the island of Chuuk, which is in Micronesia. In this research, the investigators asked the study participants, what are the things that support your healthy behavior choices? What are the things that help you sustain that for the long term? And the participants said that there are certain behaviors that influence their ongoing lifestyle and their ongoing healthy choices. That said, preparing and consuming meals, not only with family, but also with the church. Patient and group motivation, access to health foods, and a holistic view of health focused on motivation with spiritual and emotional support. Now, I know that this data is about healthy eating, and we want to be careful when applying the principles to other areas of health, but it does demonstrate the desire that individuals have for their church to be safe and supportive places. One of the participants in the study made a comment that they desire to have the church as a place where they can pray, where they can come together, where they can share and have courage for their health journey. So this desire for connection, it really should come as no surprise to us that we as human beings have this desire to have these safe places for whatever it is that we are dealing with. If we look at the foundation of where this comes from, we can actually see this in the biblical account of creation, of how God made man and woman. If we look here in Genesis chapter 2, we see 4 components identified of what makes us human. It is our physical body, but it is also that spiritual life in communication with God. But we also see that God gifted us with a mind with creative and leadership capacity. And then when God himself says it is not good that humanity should be alone, he creates a companion. Unfortunately, in Genesis 3, we then see the result of one poor decision and the result of brokenness and the result of someone entering into the world and causing destruction And I hope you know there that I am not talking about Adam and Eve, but rather to the tempter, about the tempter. The holistic design that God gave us was broken at this point. We see in Genesis chapter 3, we see that there was brokenness mentally, there was shame, there was fear, there was blaming of each other. And this brokenness disconnected humanity not only from God, but also created a disconnection from each other. However, the church has a message of hope and wholeness. In his book, Grace for the Afflicted, Matthew Stanford says this: hope is the fuel that drives the engine of mental health recovery. As long as one has hope, there is motivation and opportunity for change. The hope presently offered by the mental health care system is symptom reduction and illness management. And by the way, Dr. Stanford is a practitioner. He goes on to say, the church, however, understands that hope is more than a feeling. Hope is a person, Jesus Christ. The church's holistic view of being human offers those struggling with a mental health problem a more complete framework for recovery, because we understand the holistic view through which God created us. We can understand that it is His restoring power that affects every piece of that makeup that He has given us. So as we consider how to approach and how to engage in this area where, yes, there is still some stigma, there is still some fear surrounding this topic, we can come into it saying, you are not alone. We are all in this space together. We all experience brokenness in some area of our lives, and we can all come together to minister that hope and wholeness to each other. And it is really in that togetherness that we then are truly restored into that amazing image and that magnificent mind that God gave us. So as we go forward with the rest of our program today, tomorrow, throughout the weekend, and also into the future, let's keep in mind that it is this brokenness that we are coming together to share healing, to share hope. Thank you so much for joining us on this journey.
Erica, this is so important. As I was listening to this, it made me realize that there are so many people, maybe very close to us in our church setting, at work, who may be struggling, maybe even at home, who may be struggling with some mental health issue, and perhaps we haven't even identified it yet. And it made me think about the need to have an atmosphere, an environment where people can it's easy for people to ask for help. What insights did you get?
Absolutely. I really appreciated the resources that Dr. Everett shared. One of the places that we can start when we feel overwhelmed, like I want to help, I want to share this with people, how do I do it, is to know how to refer people, to have those resources. I think it's really important in our churches to have some of those resources displayed, because it sends the message that we know this is happening, we know this exists, and here are some places to get help. And I just love what Dr. Brower shared about the element of hope and how important that is in this journey of healing.
So important, so important. We want to engage our attendees as well, don't we? And so we want to have a conversation and allow you to have a conversation about some of the things that you've heard so far. And so we're gonna have breakout rooms where there will be a facilitator in each room and give you 10 minutes to be able to share and discuss. Now, if the facilitator loses their way en route to the breakout room, please just take a few moments and identify someone from within the group. And what will we be discussing in these breakout sessions?
Well, we're going to be looking at, and your facilitator will have these questions, but how can your church or clinic engage in the priority areas for addressing mental health, the capacity, connect to care, connecting to community. Emergency response is a very important part of addressing mental health, but it is really there to help stabilize that person, to help get them the long-term care that they may need. So how can your church look at ways of setting up support systems for that long-term healing journey? So we're going to say goodbye to our live stream audience just for now, for a couple of hours. We're going to be back here at 4:15 p.m. Eastern Time to rejoin the live stream. And again, please share this with those that you know and invite them to come back here at 4:15.
But before you go, we have a word from one of our sponsors from the General Conference of Seventh-day Adventists, Dr. Peter Landless.
Some things are all around us and we don't even know it. Air, unless it moves. Pain, unless it's ours. Mental health challenges, unless we're attuned. Be one who knows about mental health disorders, destigmatizes them, makes and is the difference.